think the theme of this conference, while we've really focused on viral hepatitis, you can see that the theme is coming together about disparities and kind of like what happened to my people kind of talk. And so I think with that theme in mind, we heard this morning from several that if you're not counted, for instance, if you don't have evidence-based practices that affect your specific population, then there'll be no evidence to base practice for your population. And so what we saw this morning, for instance, when Ray Kim was talking, he was saying how hepatitis C treatment in Asian Americans, we're not even at the point where we can think about that. Similarly to maybe hepatitis C treatment among the Latino population. And so I think it's really important, and we really need to think about the role of clinical trials and minority participation in clinical trials to try to change the landscape. And with that, I want to introduce our next speaker. Dr. Namratha Kandula is faculty from Northwestern University. She is in the Department of General Medicine, and she's a health services researcher. Her particular area of focus has been looking at cardiovascular disease in South Asians, and it's a real honor. She's also a board member of the Asian Health Coalition, Go Coalition. So it's a real honor to invite Dr. Kandula to speak to us today regarding clinical trials, what Asian Americans and really minorities should know about participation in clinical trials.
So I'm going to take a second to reorder some of my slides. If you want to get up and stretch before we start, please feel free to do that. So slide sorter. I just don't use a Mac. I've never sorted. Slide sorter.
I guess two quick questions. One, would you be willing to describe a little bit more about the mechanism in which funds will be distributed through federally qualified health centers, community clinics? And then a second question is, what do you think the impact will be on the Ryan White program as the Affordable Care Act is implemented? The Ryan White program being the program that supports a lot of HIV care.
And I'll start with the question about Ryan White first. Because there's been no, Ryan White has had, good support over the years, and there has been no move, as far as I've seen anywhere really, to change the funding or reduce the funding or talk about changing the funding. And I think it's simply because nobody really knows what the impact of the Affordable Care Act will be on the population that now receives Ryan White dollars. I think realistically, assuming the Affordable Care Act is upheld and it's full steam ahead, knowing what happens to the population that is now eligible for Medicaid, maybe for the first time, it's really an unknown. So right now, there's nothing on the drawing board I've seen changing that. The first question about the community health centers, the dollars that are awarded are generally competitively awarded. There was a round of $750-some million that was awarded just a couple weeks ago across the country. And as I say, it's a competition. And what has happened in the past is a competition that ends up a variety of factors being part of the competition. How dense is the population they're serving? How much of the underserved by different categories? So it really just depends on how the competition works out. I know in the past there'd been some criticism or worry because it seemed as though every time we started a new competition, the same ones got at the top of the list, got those funds. So this last round that just went out of grants started from where the last left off and then went from there to try to get a broader and a deeper group of community health centers. So I'm assuming that is what's going to continue. Those dollars will continue rolling out that way over the next 5 years.
Okay, shut down again for questions.
Thanks. So thank you very much. This afternoon, I'm going to be talking to you about the recruitment of Asian Americans into clinical research studies. Of course, this could be applied to other minority and underserved communities as well. So what is clinical research? So clinical research is any medical research that involves people like you, like me, and people volunteer to participate in these investigations because ultimately we're trying to uncover better ways to treat, prevent, diagnose, and understand human disease. It can include clinical trials, such as what Karen was talking about, that are testing new treatments and new therapies, but it can also just include long-term natural history studies, which are also very valuable because they provide information about how a disease might progress and the natural history and the natural courses of diseases, and why certain diseases develop in certain groups. So this is an example of a long-term natural clinical epidemiologic study that actually I run out of Northwestern University and is also run out of University of California, San Francisco. It's called the Masala study, which involves an Asian American community. In this study, we're looking at the natural history of cardiovascular disease and diabetes in South Asians. We're not giving people any interventions or any treatments. We're not giving them any medications, but we're bringing them in, asking them a lot of questions, running specific tests on them, and then following them over a 10, 15-year period to see why do they develop heart disease, what seems to protect them from diabetes, questions like that. So we've had a lot of interesting experiences in actually trying to recruit the South Asian community into this large-scale study, and this is one of the first population-based cohorts of South Asians in the United States, so should provide valuable information because South Asians have the highest prevalence of coronary heart disease in the world, and we still don't seem to understand exactly why that is. And I'd be happy to talk more about specific experiences we've had and what we've done, but that should come out in the rest of the talk. So what are clinical trials? So clinical trials are actually looking at new ways to prevent, detect, or treat disease, and they usually involve some type of treatment. That could be a drug, so it could be a medication, but it could also involve a behavioral intervention, which is a specific interest of mine. It could involve a new device or a screening test or a procedure. So a lot of people just think of clinical trials as you're going to be getting a drug. But for example, I'm involved in a lot of behavioral clinical trials. So we're trying to see how teaching people about healthy diet and encouraging them to exercise prevents diabetes. So that's an intervention. We're asking them to exercise, we're asking them to change the way they eat. So it doesn't always have to involve drugs. The goal of a clinical trial is to determine if the treatment or the behaviors or the things that you're proposing, do they actually work in this group and are they safe? Clinical trials can also look at other aspects of care, such as improving the quality of life for people with chronic illness. So you may have developed this great new intervention, but if it makes people feel horrible and it makes them miserable, it's probably not the best treatment out there. So we also look at things like their quality of life and side effects that are more psychological and things like that. So you may hear some of these terms, they're not particularly important, but it's nice to be familiar with them. So there's different phases of clinical trials. Clinical trials, and each phase has a different purpose and can help researchers answer different questions. So a phase 1 trial, it's when we're testing an experimental drug or treatment, and it's usually in a small group of people, because we really still haven't shown, does it work at all? And then we're trying to see, is it safe, and what are the side effects? In a phase 2 trial, in the phase 1 trial, we've seen this seems to show some benefit. The side effects were tolerable, and it seems pretty safe compared to what we already have, so we're going to move to a phase 2. In the phase 2 trial, we try it out in a larger group of people. We're really looking at effectiveness, so does it work? That's what we're trying to prove in the phase 2 trial, and then we're further evaluating its safety. Now, in a phase 2 trial, you're usually still working with a very select group of people. They're usually more highly motivated. They tend to be more homogeneous. In a phase 3 trial, the goal is that you've shown that this is effective in this very controlled setting. Let's try it in a larger, more heterogeneous group of people. Let's try it in more of a real-world setting and see what happens, and in a larger group of people. So those are kind of the different phases. And then once you get through that, it can be, with FDA approval, a drug could be then marketed to the public, or a new behavioral intervention could become the standard of care. So why does minority participation matter? Well, one reason it matters is because in 1993, the NIH mandated that minorities and women have to be included in clinical research studies. And the new guidelines stipulate that they have to be included in all human subjects research, They're to be included in phase 3 trials to allow sufficient power so that we can see differences and compare these different groups. So it's not enough to have like 10 Asian Americans in your phase 3 and say, we included Asian Americans. You have to have a large enough group to be able to say, did this treatment operate differently in Asian Americans than it did in the other populations? You cannot say cost is a barrier, although that's still a really big barrier that a lot of researchers face, because recruiting minorities, people with limited English proficiency and other barriers, you use more resources. So cost remains a barrier, even though you're not supposed to say it is. And then you're supposed to actually plan for outreach activities that will allow you to get these groups into your study. So just a little bit of background historically is that women were excluded if they were between the reproductive ages of 18 and 45. So that would exclude huge groups of women. And we were traditionally excluding women if we feared that there could be any harm to a potential unborn child. So a majority of women were excluded from clinical research. But these new guidelines sort of say that these are not reasons to exclude women from clinical research anymore. So what do we know about minority participation in clinical research in the United States? This study from 2002 shows a couple things. The dotted line is the prevalence of heart failure in minorities in the United States. So it's about 32%. The bars show you what percentage of minorities are participating in clinical trials that have to do with heart failure. So you can see the prevalence of heart failure in minorities is about 32%, but in the latter half of the 90s, only 13% of trials actually included minorities. So it's a very prevalent condition in minority communities, but we're not actually including them in the studies that might show us how to prevent heart failure, how to treat heart failure, how to take better care of people with heart failure. This is a similar slide that comes from the NIH and has data from 2003. And now the NIH requires that we report which of our trials include what proportion of minorities. And so you can kind of see the percentage of minorities in all phase 3 clinical trials. You can see that whites make up about 55% of the participants, and then African Americans about 28%, and then you can see Asians are about 5%, so pretty low. And then of course other groups are even more sort of unlikely to participate. And this is specifically about minority accrual to the National Cancer Institute and studies that look at colorectal, breast, lung, and prostate cancer. Again, you can see that even by race and ethnicity, if you break it down a little bit, there's differences in whether Blacks, Asians, Native Americans, and Hispanics are going to participate. So about 2% of clinical trials related to cancer involve Asian Pacific Islander communities. So why does this matter? Why do we care? And I think it's really the last sentence on this slide that says why should we care about this. It's basically because if clinical trials don't include minorities, then the question of whether or not the results of these studies are relevant to everyone across the board can't be answered. We're not going to know the answer to this question. And I think that, there's a huge new focus on comparative effectiveness research. You may have heard that term, CER, trying to see if treatment A is better than treatment B in a specific community, and then the findings of that are going to be applied to the whole US population, and health insurance plans are going to cover that. And a big concern is that if a minority group isn't going to participate in like a comparative effectiveness trial, we're not going to know, did that treatment work better in that group, but yet the policy is going to be applied to that group because it did work in that specific study. So this was a big concern when people were talking about comparative effectiveness research when the Affordable Care Act was being passed. So it's really so that we can know, does this treatment work in our communities? So we do know that fewer minority patients and physicians participate in clinical trials. Most drugs are approved without minority participation. Sometimes they use foreign data and they extrapolate it to how safe a drug might be in minority populations in the United States. For example, studies of statins on Asians in Asia. If it seems safe on East Asians in East Asia, then it's probably safe in East Asians that live in the United States. And I don't think we can make that assumption. I mean, there may be differences between the groups. We don't really know. And there's the expectation that a drug would work for everybody. So I used a little bit of lingo there. I talked about statins, I think. So that's a good example. So you may be aware of cholesterol-lowering drugs. Those are called statins, like simvastatin, lovastatin, atorvastatin, Zocor, Lipitor, things like that. One thing that we've learned is that Asian Americans metabolize those drugs at a much different rate. We metabolize them at a higher level. So we're very sensitive to the effects of statins. In the United States, the recommended starting dose of a statin, of simvastatin, is 20 milligrams. But in Asian Americans, it seems like 10 milligrams is more than enough to get their cholesterol levels to the levels that we need. But since Asians weren't initially included in those studies, we didn't have that information. So that would be an important thing because statins have side effects, and the higher the dose goes, the more potential for side effects, and you'd like to use the lowest dose possible. So I think that's an important and interesting example of how this might make a difference. Another example that I like to give is the Diabetes Prevention Program. So that is a study showing how diet and lifestyle, changing your diet, exercising more, prevents diabetes. When they did the Diabetes Prevention Program in the United States, it showed a 58% decrease in the incidence of diabetes. When they did it in a South Asian population, which has a very high prevalence of diabetes again, they only showed a 28% reduction in the incidence of diabetes. So it's like, why are there these differences? And it allows us to ask more research questions. Is diabetes more aggressive in South Asians? Were they less likely to follow the recommendations? You know, dig deeper, try to understand what's going on. Why isn't this working for everybody necessarily? So I think that I kind of covered about why we should worry about Asian Americans, but really clinical research drives advances in medical care, and so we can better understand why disparities in health exist, and then we can improve the generalizability of our research findings by including Asians in clinical research. So what are some of the challenges? Why is there lower minority participation in clinical research? Kind of the same reasons that there might be lower minority participation in various aspects of health research and healthcare access, you know, a lot of institutional barriers, like the healthcare providers may not feel like they have the time to discuss the pros and cons and the benefits of a clinical trial. There's competing demands, the trial location. So we've seen that with the that Masala study that I showed you, that takes place at Northwestern Medical Hospital. And a lot of South Asians are a little bit unfamiliar with downtown Chicago. They don't want to come all the way. They're a little bit nervous about coming to this big university hospital. And they're like, can you come do the Masala study up on Devon Avenue, which would make it much easier for them to participate. So that's something is, you know, where are you doing the study from? And then, of course, investigator barriers, which is very important, cultural differences, lack of knowledge. So they surveyed investigators on why you don't include people with limited English proficiency in research. And 85% of the investigators said, because we never even thought about including people with limited English proficiency, this is not even an issue that is on our radar screen. So people aren't even thinking about that. And then inadequate pre-study preparation, because it does take a lot of resources, translation of documents, hiring potentially bicultural, bilingual staff, and we often don't take the time upfront to prepare ourselves to recruit minorities. And then in terms of the participant or patient side, you know, people have talked about distrust of research. Certainly that could be the case. Fear of safety, you know, what's gonna happen to me? Am I gonna have a bad side effect? We do CT scans in one of our studies, and a lot of people were worried about radiation, things like that. Then limited English proficiency. Of course, cost has been a big issue. We're hearing a lot more about gas prices, you know, the same things, the same problems that people have for other things. It's gonna affect their ability to participate in research. And then lack of knowledge about the benefits. Why would I do this? And a lot of people think that this is like they're coming to participate in the study and they're gonna get a visit with the doctor and like a full exam and a consultation with the doctor. So kind of explaining what's the difference between going for a healthcare checkup with your doctor versus participating in a research study. You may not even see the doctor when you're participating in the research study, and making them understand why that's the case. So just a brief side track on limited English proficiency that, you know, people aren't even thinking about it, but it's very important. There's 25 million people in this country who are limited English proficient, which means they speak English less than well or very well. It's about 9% of the population, and then 30% of Asian American Pacific Islanders are considered limited English proficient. So if you're going to be recruiting this population, you need to think about the language barriers. And another thing that's come up, and you will have experienced this potentially as providers, is when we initially recruit people, they're like, oh, I speak English, I can do this in English. And then when we actually start the study and we're starting to ask the questions, it's obvious that they'd be much more comfortable actually doing the whole study in Hindi or Gujarati or Urdu. And so our staff is sort of prepared to do that, but that takes training and resources. And we know that language barriers affect all kinds of things in healthcare and patient and provider communication, and that is similar in terms of research. So there was a study in academic medicine really recently that looked at that. This is the same study where 85% of researchers say they don't even think about this, but only about 20% of studies include limited English proficiency populations. Some of the biggest barriers are the translation and interpretation of the informed consent in the surveys. That's the big one because you have to go through a lot of like official procedures and official translations and get them certified. So even if your staff is willing to translate the documents, they have to be certified and things like that, and that adds a lot of cost. And then in the Asian American community, there's so many languages. So it's like, which language are you gonna sort of focus on for your study? And I think that's where you have to do your upfront homework and say, well, which group is most affected by this disease? And which groups are we gonna probably see coming in the door for this kind of research study? So kind of knowing your demographics up front. So what are some things, I've talked about a lot of like the negatives, the barriers, why people aren't participating, but what are some things that we could be doing to help Asian Americans and other minorities participate in clinical research and encourage them? I think one thing that I've understood now is how critical it is to have community engagement in every phase of clinical research, especially the preparation phase. These communities are not just there to be used as research participants. They should really be helping us think about the research questions, designing them, thinking about how we're going to recruit these populations, all those kinds of things. And one of the ways I learned this lesson is, so we have that study I said, it's called masala. You may know masala in South Asian means like the spices that you cook with. Now, masala stands for Mediators of Atherosclerosis in South Asians Living in America. And we thought this was such a clever acronym, but when we actually put it on letters or our letterhead and tried to recruit people, it was a total disaster. People thought we were trying to sell them things. They thought we were marketers. They thought we were like a cable TV channel, because there's some cable TV channel called Masala. There's a restaurant called Masala. So that's something where if we had involved community members, we wouldn't have spent all this time and money coming up with this logo and then branding all our stuff with it. So now we just call it the South Asian Heart Disease Study, which is so boring, but people respond to that and they open your letter. So that was something I only learned like several months into it. We're trying to do more awareness where we go out and do workshops, community workshops, and teach people about clinical research, kind of get a buzz going about the study ahead of time. Like, you may get this letter, it's gonna invite you to participate. This is why you'd wanna participate. Sometimes I go and give talks that have nothing to do with my research, but it's a way of them getting familiar with Northwestern and establishing trust. Another important piece might be hiring community outreach workers to actually go door to door and talk about this study. So in my culture, when you invite someone to your wedding, you hand deliver the invitation. So they're not going to respond to a phone call saying, do you want to participate in my research study? But they might actually respond if you go to their door and hand deliver the invitation. And so we're actually doing that right now. We are going door to door, which is expensive, but really gets the most vulnerable kind of people in the door and like helps you understand what's going on with them. And then we've printed all our materials in the appropriate languages. You can provide transportation for people, that might be important. And then just teaching them about what are the benefits of this research to you, to future generations, to our community. And of course, the three most important things is using a personalized approach, building trust, and always showing respect. I mean, in an Asian community, in any community, those are the three things that are going to be critical. And so this is kind of the recruitment triangle, as we call it. For Asians, I think it's really important to not just involve the study participant, but to involve their healthcare provider and even their family members. So we are having a very hard time recruiting women into some of our research studies. How can we recruit women? Unfortunately, sometimes we have to talk to their husbands, and that's okay. It's like we've learned that with time, but first we introduce the study to the husbands, and then once they're comfortable with it, then we talk to the husband and wife together, and once you've got everyone on board, then the woman is willing to participate, so involving all members of the family if needed. And then when I talk about this community engagement, I think I've given you specific examples of why would you do that. You do that because it gives you a framework for why are you asking these questions. You can identify ethical concerns up front. A big concern for our communities that we work with is, what if when I participate in this study, you find something out, and then I don't have health insurance? What am I gonna do about it? So I don't wanna participate because I don't wanna know if I have diabetes, because there's nothing I can do about it if I do. So up front, like figuring out, brainstorming, how are we gonna address those issues when they come up? You know, we're doing CT scans and carotid ultrasounds on people. What if you find a complete blockage? I mean, those are pretty serious things that need attention. So kind of coming up with that algorithm. And then the community has been very helpful in helping us kind of spread the word, look at the recruitment materials, and then make sure that the questions that we're asking are culturally appropriate. So from a provider perspective, what happens when you ask? What happens when you ask your patients to participate in clinical trials? So a lot of providers think that minority groups are less willing to join in health research, but it's actually not true. There's really small differences by race and ethnicity in the willingness of minorities to participate in clinical research. So I think it's really important to ask and not make assumptions. And so then if you're gonna do that, what might you expect? So 75% of patients enroll in a trial when asked to by their doctor because they really trust their doctor's opinion. And why did they do that? It's because they said that their healthcare providers took the time to answer all their questions. So that's gonna be really important. And that they often learn about clinical research opportunities through their doctors or through their healthcare provider. So healthcare providers are really critical and important. And something that we're trying to do a better job of, which is go out and talk to the physicians that potentially, because a lot of our participants are getting letters about our studies, and they immediately take it to their doctor and say, should we participate in this study? And the doctor is like, well, I'm not sure, I don't know what that's about. So for us to take that time to go educate the providers as well is important. So what are some of the benefits? When you're talking to your patients, what are some things that you could tell them? Why should they participate? So they can get better targeted medicines and therapy. They may have access to some of the newest treatments. One thing for our study, which doesn't necessarily involve any treatment, is that they're learning a lot about their health, and it seems to kind of get them motivated to take better care of themselves. We send quarterly newsletters where they do get like health tips and things like that, which they really enjoy. And then most study treatments are at no cost. And then, of course, helping other people and future generations. So again, don't make assumptions. Ask Asian Americans to participate in clinical research. These are sort of the summary points, I think. Engage communities in every phase of the research, especially upfront, which is the hardest to do, but the most important. Really think through how you can increase the participation of people with limited English proficiency, and then ask about and assist your participants with barriers to participation. So we were initially giving a $25 incentive after the visit was over, and people were like, we don't want this, like, we don't need this $25, and can you donate it back to the study or donate it to people who really need it? But then what we started to also realize is what they did ask for is, can you reimburse us for our gas mileage? So just like psychologically, that was important to them. They didn't want to feel like you're just giving them a handout or an incentive, but it was like, gas is getting so expensive. Could you help us with that piece? So trying to make sure that the incentives align with their values, because in our community, sort of just giving them $25 for an unknown reason didn't seem to be particularly valued. And then for the women that we're dealing with, they actually want us to like pick them up and drop them off. And so we've even gone the extra mile to do that, which is tough. But if you want them to come, they don't know how to drive necessarily, they don't feel comfortable, and their family members can't take a day off. You know, it's things like that, going that extra mile for them. So a place that you can get more information, which is a great website for participants and also providers, is the Strategic Plan on Reducing Health Disparities, the NIH Clinical Center. So they developed all this infrastructure and examples of outreach that you can do to increase public awareness about research, eliminate misinformation, foster positive perceptions of research rather than negative. They have some really good videos and testimonials from participants and researchers. And then they actually have posters that you could hang up in your offices or things like that, and informational materials you could use. So definitely visit their website if this is an area of interest to you. Thank you.
Any questions for Dr. Kandula regarding clinical trials and participation? Yeah, I see all the way in the back.
Sunny from Minnesota. I have the experience in research with the Laotian community. I kind of agree and disagree some of that because the Laotian community kind of resistant for research, especially when we take the blood out and they give out to them for the medicines. They kind of avoid. And then because we thought that we are victimized, we are low income, we are immigrant, we kind of be experiment by the medical doctors. That's our perception in our community. And we have a lot of research in our community regarding about the tobacco, healthy eating, that the questionnaire, like you said, exactly what we said, when we ask some question wrong, it kind of turn the community away. And we said that how many people in your family, if somebody died in your family, and then they kind of said, you come to me and ask about my family who's passed away. So kind of another question that we have, and then ask about how many pounds per right you eat. He said, I don't measure when I eat. How much vegetable you eat. I didn't measure mango I eat. Tamarind I didn't measure. That's kind of hard for us in terms of exercise. Did you do the bicycle hardly or lightly? And they said that I don't walk, and then so have block in here, and then kind of hard for our staff to go down do the work, and then sometimes that's a lot of people did not trust the community, and like you just said, that if we publication out to the library and to the community sector, that they said that we need research, and nobody gonna turn to us. But we have to go down, talk to them, especially in hand on hand, they kind of trust it. And many things negative about it. For example, gambling, we do research. And tobacco, they're hiding and said, no, I don't have gambling problems. No, I don't smoke. My son does not smoke. I'm not smoke. But the community said, that family have been smoked for a long time. It kind of stigma that way. So I said, exactly like you said, that go down to the community, do some research, have some community member to be your consultant or advisory, give out some, each particular group, it's a different group. So I agree with you all.
Yeah, those are great points. I mean, the issue of taking blood is a big issue in some communities. And, for our study, we take like 20 test tubes of blood, but we try to explain that if you actually looked at it, it would be like 2 tablespoons, sort of things like that. But it took a long time to get people to feel comfortable with that. And one of the things is we draw a few extra tubes for genetic banking. And we thought a lot of people would refuse, but once you get them comfortable with the idea of participating, they actually didn't refuse the extra tubes of blood, which I was surprised about. But I think it's because we had established their trust. We'd done all the upfront talking and that kind of thing. But the trust and respect, I mean, you have nothing without that. That's critical. All right. Thank you. Oh.